Good afternoon. We will now start. So I'd like to welcome everybody to this pep talk. Please mute yourself, but always show your video picture. Sign in your name, your Facebook account, or email address in the chat box. Please include names of companions attending. Use the chat box to ask questions and make comments while the pep talk is on. There'll be group picture taking at the start and at the end of the pep talk. Please show your face in the video. As a reminder also, please take the online learning evaluation test exercise for mastery of learning and have a perfect score to get a certificate. The link has been placed in the chat box, I suppose, okay? And also the Facebook group. Also, as a reminder, please take LETE certificates. Try to get 50 OLETE certificates, as it will entitle you to 1 voucher for a ROJoson telemedical consultation. So again, welcome to everybody. Let's now have a group picture taking before we start the pep talk in 2 minutes. Show your face. Let's have a picture taking. 1, 2, 3. Today is March 26, so we will have this topic. So I have a patient empowerment program in which I'd like to empower the lay people or patients to take control of the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9, 2021, as shown here. And from October 23, 2021 onwards, I have been tackling health disorder courses and health issue courses. This may take 3 years or longer, depending on your enthusiasm. My pep talk today is entitled Fundamentals and Generalities in the Medical Management of Abdominal Pain. An overview. This is part of the health disorder course. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities in the medical management of abdominal pain. Some definition of terms in the title and the limitation of the coverage of my talk. I will use the word fundamental to mean the simplest and essential facts and theories which can serve as a basis or foundation and support for future and advanced information. Generalities to mean general statements of information, not covering specifics and details. And medical management, diagnosis, and treatment by physicians. So as I said last week, March 19, 2022, we took up this topic, abdominal disorders overview. And the 5 different types of disorders that were selected, that I focused on were the following: abdominal pain, abdominal mass, obstruction, abdominal bleeding, and jaundice. So in subsequent pep talk, we will tackle all of this, but today we will be tackling abdominal pain first. So the content of today's pep talk on abdominal pain will be the following. Okay, what is an abdominal pain? What are the different types, causes, how common, clinical diagnosis, paraclinical diagnostic procedures, and basic treatment modalities for abdominal pain. Let's start with the first topic. What is an abdominal pain? Simply put, abdominal pain is pain in the abdomen. However, this phrase, abdominal pain, really defies a simple and straightforward definition. It is better to explain it in terms of concept or idea and then interject it with practical meanings and uses, which I will do this afternoon. The reasons for this, why it will defy a simple and straightforward definition, because there are different expressions of abdominal pain with different English and local dialect terms being used. I will illustrate this later on. And also there are different degrees of pain with different terms being used. So examples of different expressions of abdominal pain in Filipino and English languages are listed in this slide. So you can see that there are a lot of terms. Okay. So some of these terms are in general forms: sakit, discomfort, unpleasant sensation, or simply pain. So, but these are general terms. And some of these terms are descriptive of the unpleasant sensation felt. Example, mahapdi, humihilab, tinutusok, kabag, crampy, or colicky pain. So these are samples of description of the unpleasant feeling. Furthermore, some of these terms have connotations and severity of the unpleasant sensation. Example, discomfort. It usually implies it's mild, ache, stomach ache, body ache, okay, mild. Pain and sakit, it implies more severe than ache and discomfort. I would like to recommend the following. Okay. So just make a simple definition first of abdominal pain. It is any feeling of unpleasant sensation in and on the belly or on the abdomen. Okay. So I start with this definition and this meaning, then let the person with the unpleasant sensation on the abdomen describe or amplify further on the feeling. Allow whatever descriptions to be given by the person, followed by a best effort to interpret them with the aim of identifying the source and cause of the unpleasant sensation. So whatever terms are being used, somebody, the physician or a relative, will have to interpret them with the aim of trying to identify the source or cause of the unpleasant sensation, meaning diagnosis. In the real world, oftentimes it is really not easy to describe precisely the character or nature of the pain that will facilitate identifying the cause. I will tell you why later on, but my advice is to at least try, as it may be helpful in the end in the diagnosis of the abdominal pain. As an offshoot of the difficulty in describing precisely the character or nature of the pain, it is also not easy to make a specific diagnosis just based on the character or nature of the pain. So one just has to gather more data, more symptom data, particularly on the presence of other associated symptoms, or also the sign data, so to be able to make a specific diagnosis of the abdominal pain. The reasons why it is not easy to describe precisely the character or nature of the pain, we'll start off with this concept. Essentially, the unpleasant sensation can originate from the abdominal wall from the lining of the abdominal cavity inside, the solid organs like the liver, the spleen, okay, and the hollow organs inside the abdominal cavity like the stomach, intestines, small and large. Okay. So these are the usual sources of abdominal pain. The question is, are the character or nature of the unpleasant sensation originating from these 4 different sources distinct, clear from each other? If yes, it may facilitate diagnosis right away, but in reality, oftentimes they are not distinct. So my recommendation for the general cues, which you cannot really see this in the book and the internet, okay? So my recommendation is to use these cues for the source of the unpleasant sensation. So if the pain is constant and superficial, most likely, or there's a big probability that the pain is coming from the abdominal wall. If it's constant pain, but a little deeper than the superficial one, it may be coming from the peritoneal lining. And if the pain is deeper, okay, the deepest, it might be coming from the solid organs. Okay? And if the pain is crampy or colicky, suspect or hollow organ involvement. So the situations that will make differentiation difficult. Number one, the source of the unpleasant sensation is not confined to just one organ or tissues, but it can be multiple, such as combination of hollow organs and peritoneal lining, abdominal wall and peritoneal lining, solid and hollow organs combined, etc. So it's not coming from one source, okay? A lot of times it may come from 2 or 3 sources. Another situation that will make differentiation difficult, usually in the early stage of the medical disease or mild medical condition, in the 4 sources that I mentioned, they usually produce only mild feeling of discomfort. Okay? They don't produce distinct character or pain if it's in the early stage. So that's why at times, watchful waiting may allow more distinct character or the nature of the unpleasant feeling to evolve, to show up, thereby facilitating the diagnosis. So that's the usefulness of watchful waiting, observation, and monitoring. So let me repeat my recommendations. Abdominal pain is any feeling of unpleasant sensation. Start with this meaning, and then let the patient describe whatever adjectives that he can give, okay? But follow this with the best effort to interpret them as to the source. So I will try to interpret these common terms that I usually encounter in practice. Sakit ng tiyan, sakit sa tiyan, okay? Pain in the abdomen. Okay, so these terms are not specific, usually, but it connotes that it's more severe than discomfort and ache. For sikmura, sinisikmura, it implies that it connotes that the pain is in the epigastric area, okay, in the center of the upper abdomen, okay, and usually the implication is that the stomach might be involved. So examples of medical conditions and diseases that will produce sinisikmura would be gastritis and gastric ulcer. Okay. Mahapdi, burning pain, usually referring to the stomach as the source. Humihilaw, crampy or colicky pain. Okay. It might imply hollow organ involvement. Tinutusok, piercing pain, sharp pain, whether versus dull pain. Again, it's not specific. Mahangin or may kabag, bloatedness, intestinal involvement is suspected here. Discomfort, non-specific, usually, but it implies it's mild. Unpleasant, uncomfortable sensation, again, non-specific and mild. And then ache, also non-specific and mild. So you can see the difficulty in the expressions of the abdominal pain and also the interpretation. So what abdominal pain is not? I'd like to put an emphasis here. I define an abdominal pain is an unpleasant sensation. So it's a feeling, it's a character of the pain in and on the belly. But what abdominal pain is not? Okay. It is not the same as its severity. Okay. In terms of mild, moderate, and severe, it's not the same, but it could be a kind or a type of abdominal pain. And then it is also not the same as its onset and course. In terms of acute, chronic, recurrent, paulit-ulit, progressive, etc. Okay. So that, strictly speaking, abdominal pain is not this one. Okay, it's the character of the pain that we are looking at. What are the different types of abdominal pain? Essentially, the different types will be based on the origin. As I mentioned, abdominal wall, lining of the abdominal cavity, solid organs, and hollow organs inside the abdominal cavity. So you can classify abdominal pain based on the source. As I said, the cues for source of the unpleasant sensation. Okay, so if you have constant superficial pain, abdominal wall, constant deeper peritoneal lining, constant and deeper pain, deepest solid organ, crampy, colicky, hollow organs. So this is the first cue that you can use, but this has to be evaluated further using other symptoms. So the different types of unpleasant abdominal sensation can also be based on the specific organs, okay, with a medical condition or a disease and the nature of the medical condition. Example, in the stomach, the pain can be burning, bloatedness, colicky, constant dull or sharp pain, etc. So there are different kinds of feelings that the patient can have, okay, when he or she has abdominal pain arising from the stomach. Okay. So gastric obstruction will usually give you colicky pain. Gastritis, usually burning, okay, and gastric ulcer, usually burning. Okay. Another example, if you have abdominal wall involvement, okay, the pain is usually constant, dull, or sharp pain. Another example, if the pain is arising from the colon, so specific organs, okay, so if it can be, the feeling can be bloatedness, okay, distended abdomen because of obstruction, and colicky pain, etc. There are some abdominal conditions and diseases which have typical courses. Some have chronic and recurrent track records, such as duodenal ulcer and colonic diverticulitis. And others, just one bout, and it does not occur anymore. And then there are pain which have a tendency to progress. When there is progression, it connotes serious diagnosis. So the onset and course of actions of the pain usually is also a helpful aid or assistance in the formulation of the clinical diagnosis. Okay. So when you say acute or recent, it's usually about, let's say, today, tomorrow, or within 1 week or 2. Okay, it's acute. If it's chronic, when you say it's chronic, it usually lasts for about 3 months, so longer than 2 weeks. Okay. Recurrent, paulit-ulit. Okay, so 3 episodes within 3 months. Okay. So this is a standard medical definition. Progressive, meaning it's increasing in intensity. Another way of classifying the different types of abdominal pain that will be useful in the diagnosis and urgency of treatment is based on the severity, whether it's mild, moderate, severe. So when you have severe pain, it connotes there is a greatest urgency in the treatment, in the diagnosis. So some abdominal pain Some abdominal conditions or diseases have typical severity score. Some are usually mild, some usually moderate, some usually severe. Example, the pain caused by gallbladder stones that's causing acute obstruction will have severe pain. If it's not causing obstruction, the pain is mild. What are the different causes now of the abdominal pain? So there are so many causes in terms of medical conditions and diseases that I will not be able to cover everything in this pep talk. I will just focus on the fundamentals and generalities. The general causes can be classified into two big groups, trauma and non-trauma. In the trauma causes, examples are penetrating injuries like stab wound and gunshot wound, blunt injuries. Examples will be vehicular accident and mauling incidents. And for the non-trauma causes, cancers and non-cancers on the abdominal wall and internal organs. So other examples or more specific causes of non-traumatic causes of abdominal pain, you have abdominal mass, which can either be cancers or non-cancers, abdominal obstructions, bleeding, abdominal inflammation, and the other specific a term that is being used is peritonitis. Peritonitis means inflammation of the peritoneal lining here, okay, the lining of the abdominal cavity. It can be seen in both trauma and non-trauma. Okay. The mechanism of the abdominal pain. How come there is pain? What's the mechanism of pain coming from solid organs like the liver? Okay. Usually, it could be an inflammation or stretching of the capsule. There's a capsule surrounding the liver. If there's stretching of that capsule, you can have pain. And that's why the pain is usually constant, okay, and not colicky, not crampy, because it's a solid organ. And pain from the hollow organs like the stomach, intestines, okay. There is, aside from the inflammation, it can be due to stretching and distension of the lumen. Okay. And then pain on the peritoneal lining, it's usually caused by inflammation. Pain on the abdominal wall, usually also caused by inflammation. How common are the abdominal pain? Very common, I suppose. All of us have experienced it at one time or another in our entire life. Okay. So where do you think pain occurs most frequently among the different regions of the body? Headache, chest pain, abdominal pain, bone and joint pain. So I leave it up to you to answer that based on your personal experience, because we don't have any concrete data on that. Okay. However, I will surmise that pain is the most common in the abdomen. Okay. So if we include even the mildest form of discomfort. Okay. Why? Because we eat 3 to 6 times a day. We put in a lot of external substances into our body, which can have potential side effects. Clinical diagnosis of abdominal pain. The basic processes used, as I've been telling you ever since, will be the pattern recognition process and the prevalence process. To repeat, pattern recognition process means realization that the patient's presentation conforms to a previously learned picture or a pattern of a disease. Whereas a prevalence process means the choice of a diagnosis is based on the frequency, how common, okay, of the occurrence of the disease in a certain locality, in a certain age and sex group, and in the affected organ and system. Tips in the clinical diagnosis will be the following. Utilize the basic evaluation methods first, history taking to get the symptoms, physical examination to get signs, and then process the data, the symptom and the sign data to come out with a clinical diagnosis. So here, symptom-based evaluation, then add the sign-based evaluation to come out with a clinical diagnosis. Let's start, let me amplify first on the symptom-based evaluation. Symptom is based on how a person feels. Okay. So tips here on how to come out with a diagnosis based on the symptoms. Determine the location of the pain. Try to determine the type of pain as best as you can. As I said, it's not easy. Feel for any associated symptoms like fever, nausea, vomiting, diarrhea, etc. Recall any antecedent events that may lead to the pain. Then monitor closely the pain. Monitor the course and its associated symptoms. I will amplify on this as this is very important. So first, determine the location of the pain. So you can have this classification of pain. Epigastric region, it's in the center, upper part of the abdomen. Periumbilical means it's around the navel. Pelvic region, it means below the navel. Okay. And then the other way of classifying the location will be the right. Divide the abdomen into 4 quadrants: right upper, right lower, left upper, and left lower quadrant. This is another way of classifying the location or the mapping out the abdomen. So the location of the pain is a very important cue for the diagnosis. Example, if you have pain in the epigastric region, usually the stomach, the liver, the pancreas, the duodenum, spleen, and adrenal glands can be involved. If you have pain in the right iliac or right lower quadrant, you can have appendix, and the left lower quadrant, you can have the colon, the lower part of the colon. And in the hypogastric area or pelvic region, you can have the urinary bladder. Okay. So, and then corresponding to this location, if you suspect gallbladder in this area, you can think of all the possible gallbladder diseases like gallstones. Okay, if you're thinking, if you have a pain on the left lower quadrant, you're thinking of colon, the lower part of the colon, and then you start thinking, is it caused by diverticulitis? And if you have pain on the right lower quadrant, okay, so you're thinking of appendix, and then a possible appendicitis might be occurring. The next thing to do is, after determining the location, is try to determine the type of pain as best as possible. As I said, it may not be easy. So initially, it may just be a discomfort without any distinct characteristics. Just monitor until you can be definite on the type of pain. A simple classification of pain that may have diagnostic import, okay, whether the pain is crampy or colicky. If it's crampy or colicky, you think of hollow organ involvement. If it's not crampy, colicky, constant pain, then it can be from any source. But sometimes, or most of the time, it can also come from the hollow organ, especially if it's in the early stage. Okay. Associated symptoms have to be monitored. Okay. Example will be, if you have associated fever, an inflammation or infection may be going on. If you have vomiting, possibility of obstruction is present. If you have diarrhea, possible gastroenteritis can also be present, etc. So it's important to take note of the associated symptoms, okay, together with the pain. Antecedent events may also be important clues to the diagnosis. Example, history of a recent vehicular accident. You can have possible blunt injury to the abdominal wall or inside the abdomen. Then if you have a history of recent binge eating, excessive eating, possible food indigestion could be the cause. And then monitor closely the pain. Okay? As I said, over time, the type of pain may be clearer in character to enable you to come out with a diagnosis using pattern recognition. Okay. Again, over time, the appearance of associated symptoms may enable pattern recognition of a medical conditions. So it's important to monitor the pain as the course and its associated symptoms may help you in the diagnosis. Let's now go to the sign base. Earlier, I was discussing the symptom base, okay, how you felt. Okay, now this is how what are the signs that will be gotten from doing a physical examination. Okay. It can be done by another person or by yourself also. Okay. So look and palpate. Essentially, these are the two methods of doing physical examination. Look for unusual bulbs that may suggest a mass. An abdominal mass can cause abdominal pain. Take note of that. Look for abdominal distension. The distension can be due to a mass, obstruction, okay, or fluid, and this can also cause abdominal pain. Palpate for possible presence of mass. Okay, if there's mass, it might be the cause for the pain. Palpate for the presence of tenderness, pain on pressure. Okay. If there is pain on pressure, it could be due to peritonitis or inflammation of the abdominal wall and others. So, but this has to be evaluated further. So to repeat, look and palpate for mass, distension, palpate for presence of mass and presence of tenderness. Another tip is that in looking for the specific cause of the abdominal pain, use pattern recognition of a particular medical condition and prevalence process in those with similar presentations of symptoms and signs. So if there are two conditions that might be possibly be present, okay, just choose the one which is the more common. Okay. And after that, using these processes, you come out with the primary and secondary diagnosis. Most of the time, 100% of the time, you cannot be 100% definite what it is. Okay? So you come out with the most probable and the second most probable. General statements of the diagnosis can be like this: abdominal pain secondary to non-specific cause. Okay? This is allowed as a diagnosis, and specific cause in which you specify the particular disease, if you can identify it, if the doctor can identify it. So if there are cues for a specific disorder like abdominal mass, abdominal obstruction, bleeding, and jaundice, okay, then specify first the disorder and then look for the specific cause. Okay. If there are cues for a specific disease after thinking of a disorder, then you specify the disease. Okay. Otherwise, you can settle for it, so-called non-specific abdominal pain. Okay. So, when do you say that you have a non-specific abdominal pain? In patients with abdominal pain, but without clear-cut cues for abdominal mass, obstruction, bleeding, jaundice, there's really no evidence of this, and the abdominal pain is mild. It's mild with no clear-cut characteristics and with no cues for a specific disease whatsoever, then you're allowed to come out with a diagnosis of non-specific abdominal pain. Okay, so but this has to be monitored and checked afterwards. Okay? If the pain completely disappears after few hours, few days, then it's really a non-specific abdominal pain. Okay? So non-specific abdominal pain is a reality. Okay? So not all abdominal pain will be caused by specific diseases. Illustration number 1, I'd like to give some illustrations. A patient presenting with epigastric pain, this is the area. So based on the location, possible organs of involvement, if you look at this diagram, the stomach, the pancreas behind it, and then the liver, the intestines, both small and large. So if there is no mass, no bleeding, no signs of obstruction, and no jaundice, you consider stomach first as the possible organ of involvement. As based on prevalence, it is the most common. Okay? So, but if there is jaundice, yellowing of the eyes, you think of the liver right away, not the stomach. You think of the liver right away. Then determine the characteristics of the pain. So try your best to know the characteristics of the pain to zero in onto the specific stomach condition or the disease like gastritis, gastric ulcer, obstruction, etc. Examples will be specific disease of the stomach will be food indigestion, gastritis, and gastric ulcer. If you cannot specify based on the symptoms and signs, which is not very clear, so you can tentatively make a diagnosis of non-specific epigastric pain. Okay, so that's a diagnosis. Another illustration, patient presenting with the right upper quadrant pain, this time, right upper quadrant. Okay, so based on the location, the possible organ involvement will be the liver, the gallbladder, the intestines. Okay, the stomach can also be, part of the stomach can also be involved here. Okay? If no mass, no bleeding, no sign of obstruction, no jaundice, and no liver enlargement, you consider gallbladder first. Gallbladder, because based on prevalence, this is a common problem in this setting. If patient has jaundice, then you have to evaluate the liver, okay, the gallbladder, and the pancreas, because these are the organs that might be causing the jaundice. If there is tenderness where the gallbladder is located, okay, so you have to zero in on the specific diagnosis. The diagnosis is cholecystitis or inflammation of the gallbladder. If you cannot specify based on the signs and symptoms, you can come out with a diagnosis of non-specific right upper quadrant abdominal pain, and then just monitor and wait for it to subside if it will subside. Another illustration, patient presenting with the right lower quadrant pain, and based on the location, possible common organs of involvement will be your appendix, large intestine, left ovary, okay, in females, and even the urinary bladder, the uterus can also be involved, and if the pain is in this area. So if there is no mass, no bleeding, no signs of obstruction, no jaundice, consider appendix as the first, as it is the most common. Okay, again, we're using prevalence. If there is definite, persistent, increasing right lower quadrant tenderness, consider acute appendicitis. Now this is using pattern recognition, okay? Pattern, because this is the usual presentation of acute appendicitis. If you cannot specify based on the symptoms and signs, diagnosis can be made in such a way that you can call it non-specific right lower quadrant abdominal pain. The last illustration here will be a patient presenting with a left lower quadrant pain. So based on the location, common possible organs of involvement would be your intestine, small, the large intestine, the left ovary, the left fallopian tubes, the urinary bladder, and the uterus, okay, for the females. If no mass, no bleeding, because if these are present, then you consider an abdominal mass in this area already. But if there is no mass, no other significant cues, then you consider colon as the first, because this is the colon is most frequently affected in this area. Okay. Now, if there is bowel disturbance, okay, most likely it's really coming from the colon. If there is some problems in the menstruation, most likely it's coming from the uterus. Again, if you cannot specify based on symptoms and signs, the diagnosis can be non-specific left lower quadrant abdominal pain. So let me review basic processes, okay. Pattern recognition and prevalence process, and then some aids in the diagnosis, location of the pain, the character of the pain, and then as much as possible, try to zero in on the very specific medical condition or disease. If you cannot, then you are allowed to make a diagnosis of the so-called non-specific clinical diagnosis, but you have to monitor it closely until it disappears. Okay. Then the other aids that can be used would be the onset of and course of the pain, the severity, and the so-called acute abdomen, which I'm going to explain in a few moments. So I have presented this earlier. Okay, some abdominal conditions and diseases have typical courses. Some have chronic and recurrent track records, such as duodenal ulcer, colonic diverticulitis. Others just occur in one bout and then will not occur anymore. Some will have a progression, okay, course. So this could be clues this can be used as clues in the diagnosis. Now, for the severity of the pain, again, some abdominal conditions have typical severity score. Some are usually mild, some are usually moderate in pain, some usually severe. So example will be a pain caused by gallbladder stone causing acute obstruction. Will have very, very severe colicky pain. And then if you have food indigestion, the pain is usually mild to moderate. So the severe pain, aside from implying the greatest urgency, okay, in terms of medical treatment, because kung talagang masakit, you really have to treat it right away. Okay. It also has a connotation in the diagnosis and subsequent treatment. Okay. So example will be the so-called acute abdomen, which I will now discuss. Okay. So sometimes the specific cause of the acute abdomen cannot be definitely established. When you say acute abdomen, this is a medical term that we use in medicine. It is a condition, usually with severe abdominal pain, that demands great, urgent, immediate attention and treatment. Okay? So sometimes we cannot really identify, but we have to act right away. Okay? So it is enough for the physician to decide whether it is the acute abdomen is a surgical or non-surgical abdomen. When you say surgical abdomen, it, aside from demanding urgent attention, the treatment is usually operation. Okay, so the patient has to be operated on, okay, for whatever condition that might be inside. Okay, and when the decision is that it's a non-surgical, it just means that no operation is needed for this patient. Okay? So this is a special category of clinical diagnosis of abdominal pain. Para clinical diagnostic procedure for abdominal pain, I will just mention the common instrumental and laboratory diagnostic procedures. Okay, I will not go into the details for today. Okay, so imaging procedures, examples, X-rays, okay, plain or with dye, contrast materials, ultrasound, CT scan, MRI, PET scan, etc. Okay, endoscopy, upper and lower, okay, and then blood tests, CBC, complete blood count, liver function test, tumor markers, etc. The foremost indication for a paraclinical diagnostic procedure can be stated this way: if you are not certain on the primary clinical diagnosis, and you need to be more certain or be more certain before treatment, then go for a paraclinical diagnostic procedure. And to decide on indication, the physician used two processes: degree of certainty of the primary clinical diagnosis and comparison of treatment plans for the primary and secondary clinical diagnosis. So as a rule, there is no need for a paraclinical diagnostic procedures if the doctor is quite certain of the primary clinical diagnosis, which is possible without any lab. Okay. And the treatment plans for the secondary and the primary diagnosis are the same. The competencies required of physicians managing abdominal pain, they must know the uses and indications of all known. There's so many instrumental and laboratory diagnostic procedures currently being utilized, uh, being publicized for abdominal pain, and they must use them only as needed and indicated. Okay, so they can only do this by selecting the most cost-effective one using the BRCA process. Okay. And then the last competency that's expected of the physician will be to know how to interpret the results. This is the so-called BRCA process in selecting the diagnostic procedure. Okay. B stands for benefit, R, risk, cost, C, cost, A, availability. Okay. So in the first option, first column, put down the options and then come out with data on BRCA. So I mentioned about acute abdomen. Okay. Sometimes it may not be the specific cause cannot be established, but there must be an urgent decision has to be made. Okay. So in patients with acute surgical abdomen, no time should be wasted on the paraclinical diagnostic procedure just to establish the definite cause. A surgeon should operate without establishing the specific cause, because the operation can serve as a paraclinical diagnostic procedure as it will establish the cause, and also at the same time, it will solve the problem. It might save the life of the patient in a timely manner. The last topic is basic treatment modalities for abdominal pain. Okay. So the basic modalities are the following: surgical, non-surgical, potentially surgical. When you say surgical, it's an outright surgical condition that needs operation. Non-surgical, it's a no operation is needed at all times. Okay. Potentially surgical, it might be surgical, operation might be needed when there is progression of the symptoms and signs. Okay. So in the first column, you just list down the disease conditions, okay, and then try to tabulate whether it's surgical, potentially surgical, and non-surgical. So examples of outright surgical abdomen would be the following: acute surgical abdomen. If the surgeon has decided that whatever be the internal, the cause, specific cause inside, the patient needs to be operated on. Okay. Then complete intestinal obstruction, peritonitis, secondary to ruptured intestines, and operable tumors. Okay, so these are examples of outright surgical abdomen. Surgical treatment that are usually being done in the abdomen or for the abdominal pain will be drainage of infections, abscesses, removal. Our medical term here is ectomy, a suffix, such as cholecystectomy means removal of the gallbladder. Gallbladder is cholecyst, okay. Then ectomy is removal. Then the last type of basic surgical treatment will be repair, okay, raphy, okay, such as gastrorraphy, okay, repair of a stomach, gastrostomach, stomach ruptured, laceration, etc. Examples of potentially surgical abdomen would be asymptomatic gallstones. There's gallstone, but it's not causing symptoms, so you don't have to operate on that. And then if it becomes symptomatic, then it becomes a surgical abdomen. Asymptomatic diverticulitis, incomplete intestinal obstruction in which observation can still be allowed. Asymptomatic benign tumors, which is not causing any problem. So you can leave it there for a while and observe. And examples of outright non-surgical abdomen will be gastroenteritis due to inflammation, food indigestion, cirrhosis, and hepatitis. So non-surgical treatment examples would be the use of medicines. There are a lot of medicines that can be used for different types of abdominal conditions. Or the other option is no medicine at all, just watchful waiting and natural support management. So this is the BRCA process in selecting cost-effective treatment modalities. So summary, I have discussed the following on abdominal pain. What is, different types, causes, how common, clinical diagnosis, paraclinical diagnostic procedures, basic treatment modalities for abdominal pain. So this is just an overview. Okay. Takeaway in relation to patient empowerment. Be always in touch with reliable medical information on fundamentals and generalities in medical management of abdominal pain. Knowledge is power, it gives power. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of abdominal pain. So with that, I end my pep talk. Okay. Fundamentals and generalities in medical management of abdominal pain and overview. I hope I have empowered you to have a better understanding of the fundamentals and generalities of the medical management of abdominal pain. So before we go to the question and answer and interactions, as a reminder, please take the online learning Cook evaluation test exercise for mastery of learning, and try to get a perfect score so that you can have a certificate. And then if you get 50 or latest certificates, you are entitled to 1 voucher for the ROJoson telemedical consultation. So let's now have a group picture taking before we start the QA and interactions. Okay. Are you all ready? 1, 1, 2. Okay, may paabol. You want to show this? Okay, ready na? 1, 2, 3. Let me save it first. Okay, the floor is now open for questions, comments, suggestions. I have to confess that this is a very long lecture today, okay? But I cannot divide it into part 1 and 2 because there will be I will be losing the connections. No, okay. So do you agree if I have to divide it into 2? Hirap eh, no? Baka you might lose track, no? So anyway, actually there's still a lot to discuss on abdominal pain, no? So we will dissect it bits by bits. Example, probably next time I will be focusing on based on location. That's importante in location as a first cue, no? So I'll be talking about right lower quadrant pain, no? Okay. Then using acute appendicitis as a typical example. Then probably the subsequent sessions will be right upper quadrant pain using gallbladder as an example. Okay. And then in those particular modules, I'll now be discussing in details what are the diagnostic procedures, paraclinical diagnostic procedures that can be done, and what are the treatment that can be done. Okay, so that's my plan. Is that agreeable to all of you? To tell you honestly, it was not easy making this lecture for you today. Okay, I try to simplify it as much as possible, as best as I can. No? So any question that you want to ask? You can share your experience of an abdominal pain. And you can ask specific questions already for today. No? So this is just an overview, but you can ask more specific conditions. Any questions? Anything on the chat box? Ladies, Abet, anything on the chat box? No questions.
There is no question at the chat box.
Okay. So,
but I think Delhi is recommending Engineer Severino to Menes. I think he has a question.
Severino Menes.
Yeah.
He has a question.
Yeah, that's Engineer to Menes.
Okay. Good. Go ahead.
Yes, Doc. Good afternoon.
Good afternoon.
I've just gone to ultrasound and CT scan.
Tagalog.
Sige.
Tagalogin.
Hello, Doc. Yes, ma'am. Tagalog na lang.
Okay lang. Go ahead. Tagalog or English? Pwede rin.
Okay, Doc. Actually po, Doc, kagagaling ko lang po. The other day lang na nag-undergo ng ultrasound saka CT scan regarding with my kidney. Then ang findings po dun sa ultrasound saka CT scan ay mayroon pong bato na nakabara dun sa may kidney, right kidney, measuring to 15 millimeter by 6.8 millimeter by 8 millimeter, Doc.
Okay, so anong gusto mong tanungin? Can you go direct to the point? Anong gusto mong tanungin?
Ang tanong lang, Doc, dito kasi yung urology na nag-assist sa akin ng, sabi niya, surgical, that means operation lang pwedeng gawin agad. Pero sa akin naman, ang katanungan ko sana, Doc, wala bang ibang mga remedy muna na itry bago mag-undergo ng operation?
A direct answers to your question, kung may mga options, may mga other remedy, palaging meron, no? But you have to decide. No? We have to analyze it. No? I will go back to that issue. Your main issue is that kung anong mga options, di ba?
Yes, Doc.
But okay, let me, for the sake of our learning in this session, so he has a kidney stones, okay? Whether it's on the right or left, I don't know, okay? But I think he has probably what I don't know. I still don't know. But I'll ask Severino. Okay, so there could be some pain that led to the diagnostic test. Okay, or baka incidental. Incidental means baka natsambahan lang, nakita, wala ka, no? So do you have symptoms? May pain ba? Or bloody urine?
Ang naging symptom lang, Doc, siguro minsan naging sa likod, may sakit sa likod, pero bloody urine, never ko pa naman na-experience yun, Doc. Wala naman.
Okay, so location of the pain is one thing that in relation to our topic, now she has pain, okay? It so happened that it's at the back pain, no? So ganun din ang principle. Kung nasaan ang pain location, i-zero in nyo, doon yung i-focus, no? So on the back pain, usually yung sa itaas, no, kidney ang pinag-uusapan, okay? So you
Yes, Doc.
kidney. So when you are suspecting kidney, then it could be initially kung early stage lang, yung maaga pa, walang masyadong clear-cut na symptoms, no? Okay? Okay. So you can observe, but pag lumabas na yung mga masakit, palaging persistent ang pain, progressive, no, then you really have to do further investigation. Okay? So I think most likely that was the case kasi nag-bothered na siya, no? So he went for a diagnostic test, no? Okay? So the first mga options for diagnostic test will be, number one, when you're suspecting kidney, you can have urinalysis, no, to check if there is something abnormal in the urinalysis. That's the first and the simplest. And then, kung may nakitang RBC or blood, no, or anything there, no, so you can go a little further, do yung mga more sophisticated diagnostic tests like the ultrasound, and then kung kailangan, CT scan. Pero hindi pwedeng, usually hindi ko sinasabay yung ultrasound and CT scan. Ultrasound first, no? Kumisan kasi yung ultrasound can give the diagnosis away already. Alam na natin with 98, 99 accuracy, and then you don't need to have CT scan, no? Okay? So let me stop at this point first para i-apply natin to what we have learned, okay? If you don't mind, no, Severino, I'm trying to use your questions, no?
Yes, Doc.
To apply what we're learning today, no? So nagpa-CBC ka ba? Ay, nagpa-urinalysis ka ba?
Yes, Doc. Nagpa-urinalysis. Yes, Doc, meron.
May RBC, may blood?
Actually, during that time, ang nakuha nilang Doc, is 140/90.
Yung blood, the RBC is blood.
Regarding creatinine, Doc?
Hindi. Yung RBC, yung sa urine, kung may blood, may RBC. Okay, anyway, baka meron. So you check that. Kung meron, then you go for one step higher, ultrasound. So ano yung ultrasound may nakita?
Doon sa ultrasound, Doc, on the right kidney, mayroong 1.5 centimeter stone at the middle of the ureter.
Ureter na, okay?
Ureter, Doc.
Yung ureter, usually, okay, ureter, alam niyo yung ureter, no? Yung daanan ng ihi, no? Okay, sa middle part, no? So if you look at the ultrasound, is it causing obstruction? Ibig sabihin, namamaga yung nasa itaas ng ureter mo?
Di naman, Doc. Actually, yung impression doon sa CT scan report ang nilagay.
Hindi, yung ultrasound muna. Ako, one by one ho tayo. Sorry kasi late ka pumasok dito sa amin, but you're welcome to join in. But we're trying to be systematic in our analysis. Okay?
Okay, Doc.
So,
Thank you.
So kung sa ultrasound, as I said, kung minsan pwede na yung ultrasound without going to CT scan. Pero a lot of practices by a lot of doctors, they do a lot of things which may not be really necessary. Okay? So kung meron kang ultrasound that shows that may stones na, tapos hindi naman namamaga yung sa itaas kasi pag may bato baka nagbabara, di ba? Pwede magbara yan, di ba? Okay? So,
yes, Doc.
So anyway, whatever be the reason, I don't know, pina-CT scan ka, no? Okay?
Yes, Doc. Yes, Doc.
So, CT scan baka na-reinforce lang naman yung bato. May bato ka diyan, di ba? Okay? So, kung may bato ka diyan, usually tatanggalin ang bato. Because it will be causing the obstruction, di ba?
Yes, Doc.
Kasi kung lumulutang lang sa kidney, doon sa loob ng kidney, hindi nagko-cause ng obstruction yon, baka pwedeng hindi tanggalin, di ba? Okay?
Yes.
Pero kung nasa ureter na, buwaba na, okay, baka nagbabara na, kailangan tanggalin, di ba? Okay? When say tanggal, it's an operation. Again, there are a lot of options for operations that we're using the BRCA. Diba? Option 1 could be, first column, lagay mo yung options. No? First column will be pwedeng maraming klaseng operation that can be done there. No? One is blast, yung mga ER, yung blast, yung ESW. Okay? ESW kalimutan ka, ESWD, no? Okay. And then the other one is open. The other one is susungkitin kung kaya from below. Okay. So maraming options yan, no? Okay. So now, then you try to compare based on benefit, risk, cost, availability, benefit, what will be the procedure that will get the that will bring the best results, successful removal. No? Okay, is it the
Yes,
flap?
Doc. Okay.
Is it the sungkit or the open? No, open meaning bubuksan ka, hahabulin yung bato, tatanggalin. No? Okay. Then you also compare the risk, no? The risk, baka yung blast walang hindi siya masyadong invasive, dudurugin lang, no? Okay? Yung sungkit medyo may instrumento, no? Nadaan sa bladder mo, then susungkitin, no? And then yung open, bubuksan, no? Okay? So i-compare mo lang yung mga risk, no? Okay? And then compare mo na rin ang cost, kung magkano lahat, no? Kung magkano isang procedure, gano'n, no? Okay? Then, I suppose in this era, modern times, all are available, no? All are available. Kasi minsan, may mga hospital na hindi available in isang procedure, no? Gano'n. So then make a decision. Make a decision based on the comparison, no? Okay?
Okay, Doc. Thank you.
So that's
Anyway,
that's how you decide.
yes, Doc. Yes. Anyway, based from the result of the report, diniscuss dito, Doc, that the liver, gallbladder, spleen, and pancreas are normal.
Okay.
Remark.
Okay, Doc. Okay, thank you. Thank you.
Okay. Sige. So the other option is tingnan mo rin, baka pwede pang, alam ko, the least option will be yung medicine. Baka magtatanong ka, meron pang gamot na magpapatunaw, di ba?
Yes, Doc. Yun po, Doc. Actually, yung the main purpose na with the help of Madam Oson. Kaya naki-join dito para matanong lang kung baka mayroon pang ibang option makukuha pa na hindi naman kailangan ng operation agad. Baka may medicine na pwedeng pang gamitin para matunaw. Not necessarily na mag-undergo agad ng surgery, Doc. Thank you. Thank you, Doc. Thank you.
Okay. So I cannot answer you directly on that. I can just give you the yung mga processes, no? Yung principles. No?
Okay, Doc.
So you have to look at the track record kung anong klaseng bato, pwede bang tanong mo yung urologist mo or nephro. Usually urologist. Gusto mo nephro, no? Kung yung type of stones, baka pwedeng matunaw ng gamot, gano'n, no? Okay.
Okay, Doc. Thank you. Thank you, Doc.
Okay. Any more questions?
Doc,
Phoebe.
ano yung cholelithiasis?
Cholelithiasis. Chole is gallbladder. Chole. C-H-O-L-E. Chole. Lithiasis.
Chole.
When you say chole, it's
Cholelithiasis.
Okay. Lithiasis means stones, bato. Okay? Nephrolithiasis means bato sa kidney. Nephro. Okay? Chole means nasa biliary system. It could be the gallbladder or the common bile duct, yung daanan ng katas ng atay. Now, but if the doctor wants to be more specific that there is stone in the gallbladder, ang tawag noon cholelithiasis. Now, kung ang tinutukoy ang bato ay nasa common bile duct, yung daanan ng katas ng atay papunta diretso sa intestine, hindi na dumadaan dun, hindi yung gallbladder, you call that choledocholithiasis. Okay? So, pero if you're asking a question based on the report by the ultrasonographer, palagi,
Yes, Doc.
okay, alam ko yun, no? They don't specify. No? Kaya sabi ko, the practice of medicine is a lot of times confusing a lot of uncertainties, a lot of inexactness. No? So,
Kasi yun ang impression nung sa ultrasound ko, Dok.
yeah.
Whole abdomen.
Kaya nga. So, kaya ito kung minsan sinasabi ko sa mga radiologists, huwag niyong gamitin yung cholelithiasis. Just use cholecystolithiasis. If you mean that there is stone in the gallbladder. Okay?
Okay.
Okay? So, kung minsan, we just have to inform the radiologists on how to use the terms, no? Yung mga terminologies, no? Okay?
Eh, what about yung left mild pelvocalectasia?
Okay.
Sa
Parang
lower quadrant sa left side. Sa left lower quadrant yun, Dok.
when you say pelvial calectasia, sa kidney yun. Sa kidney yun. Sa kidney. So, ibig sabihin dilated yung ano.
Left mild pelvocalectasia. Kasi minsan, Dok, kumikirot din yung aking ano.
Ito yung
Ayan.
kidney. Ito yung kidney.
Okay, Dok.
Okay. So, pag may bara dito, may nagbabara, may bato, parang kay Mr. Severino, kumisan, pag may bara dyan, lalaki ito. Okay? Kasi hindi makapasok yung, hindi makapasok yung ihi, di ba? So, mag-distend ito. No? Okay? So, pelvial calectasia means ito, mas malaki lang compared to the other side. No? Compared to the other side, baka ganun lang kaliit yung sa kabila, no? So, yun, yung pelvial calectasia means distended yung pelvis area ito, pelvis, no? Okay. Part of the kidney yun, no? Okay? So, kung mild lang, it could be, as I said, there's such thing as non-specific, no? Wala naman talagang sakit. No? Okay. So doctors will have to determine whether it's a non-specific condition or a disease is present already. No? Na kailangan.
Yes.
No? Okay?
Yes, Dok.
Okay. Any more questions? I think
Ay,
it's
thank you, Dok. Yun kasi ang ano.
Yeah, there is a question from Melingo. Doc, when is gallbladder required to be removed? What is the effect if gallbladder is removed?
when is the gallbladder required to be removed? It is required to be removed if there is a disease that really needs removal. That's the simple, that's the straightforward answer. No? So ano yung disease? No? Disease will be, you might have gallstones. Okay, you may have a tumor in the gallbladder, which is very, very rare. No? Okay, ang pinaka-common noon is gallstones. No? And then you can also have tawag na cholecystitis, inflammation of gallbladder. So these are the three common conditions of the gallbladder. Tumor, cancer, very rare. Okay? The point that you don't think about it. Number two, cholecystitis, no, and gallstones. No? Usually when you have gallstones, you have accompanying cholecystitis, no, inflammation. No? But you can have cholecystitis without gallstones then. No? Okay, that's why I put cholecystitis as a number three, a third condition. No? So once you have these three conditions that it's causing problem, okay, then you have to remove it. Okay, but if it's not causing, let's say the stone is there, no, tahimik lang siya, hindi ka nasasaktan, you can leave it for a while. You can leave it there, no? Okay. Kung kasi pwede naman pabayaan lang dyan muna, you observe lang. So the moment that you feel something, then it's time you have it removed already. Kasi Parang may track record na ginugulo ka na, so kailangan tanggalin na. No? Okay. Kung wala naman, just leave it there. No? Okay. Just, kuminsan diet will help. Sometimes no, we don't know. Okay. So just avoid eating a lot of fatty foods because yung fatty foods will trigger your gallbladder to contract para lumabas yung bile to assist in the digestion of the fat. Okay? Okay? So if the gallbladder is removed, halos wala naman. Just like the appendix, tanggalin mo yung gallbladder. Kasi gallbladder is just a reservoir ng bile. No? Okay. So you can live without the gallbladder. It will not shorten your lifespan. No? Ganon din sa appendix. You can remove the appendix, no? Without hampering your lifespan. Okay?
Okay, before I read the question of Daddy Lim, may I ask, is there a difference between cholecystitis and cholecystolithiasis?
Cholecystolithiasis is stone, bato, inside the gallbladder. Okay. Cholecystitis, tandaan mo yung itis, kanina may lithiasis, bato, cholecysto. Pareho may chole, di ba? Pareho may chole. So, chole is also gallbladder, pero may itis, cystitis. So, inflammation of the wall of the gallbladder. The wall. So, once you have a stone, you can also have inflammation. Diba? Okay. Now, you can also have no stones, pero nag-inflame lang siya. No? Okay. Okay.
Okay. Here is the question of Daddy Lim. Doc, when you are operated on the thyroid, is there a possibility that it will come back again?
Okay. Bakit napunta sa thyroid?
Medyo lumayo.
Okay. Okay, the answer is always yes. There's also a possibility it will come back. Tandaan mo lang yung principle in life, in buhay natin, because of the original sin. Because of the original sin, we will always have these recurring problems until we die. Okay, so the moment you're operated on, it's still possible it can recur. Okay, ganon. Pero usually, you just to answer to see whether what are the chances of recurrence. Maraming data that you have to consider. Number one, what is the disease itself? Is it cancer? Okay, so if it's cancer, mas malaki ang chance na mag-recur compared to a non-cancer. But for non-cancer, sa lecture ko sa goiter, di ba? Nag-lecture na ako. It's also possible that it can, kahit na non-cancer, it can create problem. No? Okay. So now the other one is another condition that you have to think of aside from the disease. No? Yung kung yung gamot na, baka may mga gamot na it will try to avoid its recurrence. No? Okay. May mga gamot na it can try to avoid. Yung mga for the MCAG, multiple colloid adenomatous goiter, no? So you can take medicine in an attempt to avoid recurrence, no? Okay. But again, all of these are not sure shot, no? Okay. So there's always a possibility of recurrence. No?
Okay, thank you, Doc.
Okay. So any more questions before we call
Doc,
it? Okay.
may tatanong ako.
Oh, sige.
Doktor, bakit minsan yung tiyan ko parang may tumunog-tunog, may tunog-tunog? Hindi naman siya masakit. Kaya lang pag alimpa nakahiga ako, parang may tunog ba na hindi ko ma-explain eh.
Who would like to explain? Sino may experience na?
Yung mga parang matunog, yung ganun parang kumbaga.
Okay. So, I think one of you will have the same experience in the past.
Yeah, ako.
Sino?
Ako rin daw. Minsan.
Oh, matunog.
Okay.
Tumutunog.
Sige.
Parang, ano yun, gutom or what?
Ano?
Kahit
Oo, lalo pag nakahiga ako, doktor, pag gabi, parang sabi ko, ba't parang ang tunog-tunog naman yung tiyan ko? Oo, hindi naman siya masakit, doktor.
parang growling, gano'n?
Oo, parang ganun.
Okay. Anybody else? So, si Phoebe experience.
Ganun din ako minsan, Doc.
Anong ginagawa mo para diyan?
Wala lang.
Wala
Inom ako
naman.
ng warm water.
Okay.
Ano ba yung dahilan, doktor?
Okay. So, okay, walang pain, tumutunog lang, no?
Oo, opo.
Okay. I suppose all of us have experienced that, no? We can
Ah,
once in a while we hear the sound, di ba?
Yeah.
opo, may sounds.
Nagko-contract lang yung ano mo, nagko-contract lang yung stomach mo.
Ah.
Malakas
Ah.
na yung contraction, no?
Ah,
After a while, nawawala naman, no?
Yes,
Okay.
Doc.
So,
pero hindi naman nakaka-apekto yan, doktor. Wala namang no effect naman sa intestines, mga ganun. Hindi naman.
wala. Kasi nawawala naman eh, di ba? Kasi
Opo.
yan tinatawag na non-specific medical conditions. No? Tandaan mo
Ah.
yung non-specific. It will just disappear. Okay.
Opo.
Don't put too much importance after you have observed. Pag na-observe mo, nawawala, pabayaan mo na lang. No? Okay. It will go away.
Hindi, Doc,
Yeah.
hindi ba symptoms yun na parang gutom? Gutom ba? Hindi naman.
Hindi naman kasi katatapos
Feeling-
gabi.
Feeling lang gutom. Feeling lang gutom kasi nga, yun nga kung sabi niyo, Doc, nagko-construct yung intestine. Grow yung tiyan.
Hindi, kahit na hindi gutom, kumisan, magko-contract na lang yung intestine mo.
Opo, nagpo-contract nga.
Oo.
Minsan nga, pinakonsulta ko, binigyan niya ako, doktor, ng pampakalma, ng bituka daw. Sabi niyo,
Sana in-observe mo na
binigyan
lang.
ako ng pampakalma ba? Ano ba yung gamot na yun? Binigay sa akin ng doktor.
Hindi
Minom
na-
ako ng 1 week.
Hindi
Oy,
na-
tapos,
hindi
hindi
na-
naman nagamot. Nagpo-contract pa rin.
Oh, paulit-ulit lang yan. Kaya
Opo.
non-specific, you don't need medicine for that. No?
Ah,
Kaya importante yung sinasabi natin, itong pep talk na para matutupad.
Non-specific.
Okay? Okay? So kung di niyo kabisado itong non-specific, when you consult, kung you consult a doctor, hahanapan kayo ng isang specific disease. At a lot of times, they will not tell you kung ano siya kasi hindi nila
tama nga, doktor. Kasi gusto nila magreseta ka agad ng gamot.
Reseta na lang. Reseta na lang. Para tumahimik ka na.
Kasi minsan kasi, doktor, nakakagulat ba? Parang malakas ba na tunog ng tiyan ko? Pag ginagawa itong mga bituka ko, parang
Normal lang yan. Normal lang yan. Okay lang.
normal pala.
Just remember. Just
Tayo lang
remember.
nagsabi, doktor, na normal. Yung mga ibang doktor nagreseta ka agad ng, bibigyan kita ng pampakalma, mga ganun ba?
Okay. Any more questions? Okay. If there are no more questions, who's that? Yeah, Maria. Yeah.
Good afternoon. Well, I want to share sa my mom when nagkaroon siya years ago ng ovarian tumor. Now, she had been large woman lang. Pero we noticed na people really thought na buntis siya. Especially pag humiga siya, kasi pag belly fat po, ibang what I understood, pag belly fat, your fat goes to the sides when you lie down. Pero siya talaga, kahit na nakahiga siya, malaki yung kanyang abdominal fat. Slippers, they remove a very large. So, ganun po ba talaga ang mga tumor? You can see that the distension is there even when you're lying down. Is that prerequisite on it being a mass or a tumor as opposed to fat?
Okay. So medyo choppy pero I'll try to get answer. So yung okay. Rule number 1 is that there are a lot of different kinds of presentation ng tiyan. Okay. Maraming klaseng presentations that kumisan mahirap talagang gamutin. No? Okay, that's why ito nga, inattempt mo na to make it simple para magamit natin lahat. Okay. So, yung tumor can be, may mga tumor na madaling kapain. Okay. Yung iba, mahirap. Okay. Not only in terms of size, kung talagang malaking-malaki kapag kapana, di ba? Okay. Then, pero kuminsan, pag kinakapa mo, wala kang makapang bukol, pero malaki ang tiyan. No? Okay? So you have to consider other things. This is before doing the diagnostic, yung parang clinical diagnostic procedure. Tingnan mo kung baka talagang mataba lang siya. Di ba? Okay. Or, titignan, kuminsan, that's why you ask, kailan pa yan? Kung palaki ng palaki, within 2 months, 3 months, no? Something is going on. Something wrong is going on. No? Okay? So, kakapa-kapain mo rin. Kung di ka sure, that's the time you do the paraclinical diagnostic procedure. Kung maliit lang, mas mahirap kapain talaga. No? May mga tao talaga yung build niya, talagang biglang taba, mahirap na rin kapain. Minsan tubig, baka tubig din yun, di ba? Okay. So you just have to, that's the time that you have to do the ultrasound, the imaging procedure. Okay. So lumabas ko variants, variant tumor.
It was big. I mean, they do the hysterectomy as what they do.
Okay. Yeah. So
Very.
Okay. Any more?
No more
questions? So if there are no more questions, okay, last call. We call it a day. Wala na? Okay.
Wala na
And the chat box.
Okay, so we call it day. The next, I will zero in on right lower quadrant next week. Right lower quadrant.
Right lower quadrant.
Abdominal pain. Now, with appendicitis, with focus on appendicitis. Now, okay. Okay?
Yes.
Okay, Doc. Okay, Doc.
Sige.
Thank you, Doc.
Very much.
Thank you, Doc.
Thank you so much.
Thank you.
Bye. Thank you.
Load kasi walang load ko dito. Andiyan mo yun.